Oh, this pain in my leg is really bothering me today. I hope it eases up soon.
Welcome everyone. In this question, we have a 50-year-old woman with a history of smoking, hypertension, atrial fibrillation, and type 2 diabetes presenting with a 2-month history of left leg pain while walking. She used to walk 800 meters, but now must stop after 200 meters due to pain, which resolves after 5 minutes of rest. Exam reveals an irregular pulse, a cooler and shiny left leg, and diminished left pedal pulses. Femoral pulses are intact bilaterally. She's on metformin, enalapril, aspirin, and warfarin. What is the most appropriate next step in management? A. Duplex ultrasound. B. CT angiography. C. Ankle brachial index. E. MR angiography. So the presence of claudication pain, trophic skin changes, and diminished pulses in a chronic smoker should raise concern for peripheral arterial disease or PAD. So if you have these three things the patient in the question stem has, then they most likely have PAD. If you need a mnemonic to remember these three symptoms, the name of the disease will also tell us the important symptoms that it will present with. P is for pain, mainly claudication pain, which is cramping pain in the legs that starts during exercise and it gets relieved during rest. A is for altered skin. So there's going to be trophic skin changes in PAD, and they occur due to insufficient blood flow and oxygen to the skin, and so that causes the tissues to die, and so it leads to the thinning of the skin as well as hair loss on the skin. D is for diminished pulses, which occurs due to narrowed or blocked arteries, and the blockage occurs primarily due to atherosclerosis, and that restricts the strong rhythmic flow of blood that would create a palpable pulse, and so we will get diminished pulses. Because the patient most likely has PAD, we need to do a ankle brachial index, or ABI, which is going to be the first-line diagnostic test in PAD because it is going to be readily available, it is non-invasive, as well as being highly specific and sensitive in its diagnosis of PAD. So reduced ABI values between 0.4 and 0.9 would indicate mild to moderate peripheral arterial disease with claudication, whereas values below 0.4 correlate to severe PAD with resting pain. An ABI greater than 1.4 in patients with suspected PAD may indicate calcific sclerosis with non-compressible vascular walls that can occur in certain patient population like diabetes. A low ABI less than 0.9 and a high ABI greater than 1.4 is going to be associated with an increased risk of all-cause and cardiovascular mortality. In patients with a normal ABI and a high suspicion for PAD, exercise testing may be required. Vascular imaging like MR angiography is not required for diagnosis, but it will help assess sites and extent of arterial occlusion or stenosis, as well as collateral blood flow if revascularization is planned. So thank you for watching. Hopefully this video was helpful.